Good evening to all, sir. So we will start with the first article. The article is about high and intermediate risk pulmonary embolism in the ICU, and this article was published in Intensive Care Medicine journal in December 2023. This article, the abstract of this article is to highlight uh, the epidemiology, diagnosis, risk stratification, and particularly about the management of the PE. One second, sir. Sorry. Yeah. About the pulmonary embolism from the critical care aspect. So we will be discussing about the issues which are around prevention, anticoagulation, fibrinolysis, catheter-based, and the newer technology what are present today and what are evolving. So this article talked about the epidemiology, the risk factors, and the clinical presentations as it can be tachycardia, dyspnea, saturation, decreased saturations, and stratified the patients in high risk and intermediate risk. High risk patients were the patients they kept when the patient is having end organ perfusion defect like or hypotension, severe hypotension, and the intermediate risk. And the intermediate risk they have divided into high intermediate and low intermediate on the basis of troponin and the echocardiography after the echocardiography. Sir, this is the article about how high and intermediate pulmonary embolism in the ICU. It was published in Intensive Care in December 23. The abstract was paper talk about the epidemiology, the diagnosis, risk stratification, and particularly about the management of the pulmonary embolisms from the critical care perspective. It also talks about prevention, how to prevent anticoagulation, fibrinolysis, and catheter-based techniques, which are the newer techniques, surgical embolectomy and ECMO. So in these are the highlight of this topic, this article, which I've talked about the epidemiology, risk factors, and clinic presentations, like the patient is having tachycardia, hypotension, and hypoxemia, and prevention of the ICU acquired pulmonary embolism, like pharmacological approaches, in which talk about the low molecular weight heparin versus the unfractionated heparin, in which they have said that LMWH is a little superior than the unfractionated heparin, though both have the risk of bleeding. Mechanical approaches like the IVC filter they have talked about, and along with that, intermittent pneumatic compression devices they have talked about. And about the risk stratification, they have stratified the patient in high risk group and intermediate risk group. The high risk group, they have kept the patients who have presents with end organ perfusion defect, the patients who are having severe hypotension, and may have impending or cardiac arrest or impending cardiac arrest situation. Intermediate risk, they have kept intermediate high and intermediate low. In the intermediate high group, they have kept the patient who are having hypotension, tachycardia, or hypoxemia, that is saturation less than 95%. And along with that, if the patient is having 2D echocardiography and troponin positive, they are high intermediate risk patients. And about the diagnostic strategy, we have talked about the patients who are having low probability and high probability. So the patients who are having low probability in not may have to go, we have to check for the other investigations like D-dimer and then CTPA if required. In high probability patients, D-dimer is not necessary and you can go ahead with CTPA if the patient is clinically stable. And if not clinically stable, then we can go ahead directly with the fibrinolysis. The assessment of the severity they have talked about with the simplified version of the SPC score, in which they have kept the scores like hypotension, tachycardia, saturation, history of malignancy, cardiopulmonary disease, and age factor. These are the factors they have kept. Along with that, on the basis of right ventricular dysfunction, in which they have talked about RA and RV and PA, pulmonary artery coupling, and along with that, TAPSI and PSP ratio they have talked about. Biomarkers which are important in these patients are troponin and the NT-proBNP, what we can look after. Organ support, when we talk about these patients present with hypoxemia, and we can give oxygen support either via nasal cannula, HFNC, and what are the SpO2 targets we have more than 95, and whether to intubate these patients and to put on the invasive ventilations, because already they have RV dilatations and increasing the positive pressures can worsen the condition. Fluid strategy, like they have talked about, initially the patients were given a large amount of fluid thinking about the hypotension, but now due to interventricular interdependence, whether we should give fluid or it should be very judgmental if there is any role of CP in these patients, and how much of the fluid we should be given, the patient should be given. In catecholamines strategy, they have talked about norepinephrine, which remains the first mainstay drug. They have talked about dobutamine because the dobutamine, it increases the LV contractibility. Though in these patients already the LV is hypercontractile, and it is the interventricular RV is pushing the LV, not the contractibility. So dobutamine can harm in a higher doses. They have talked about the levosimendan and vasopressin. And about the pulmonary vasodilators like nitric oxide if inhaled, and is there any role of sildenafil in these patients if having a high PA pressures with post-EP. Anticoagulation, they have talked about UFH and LMWH. Along with that, IVC filter. Fibrinolysis, IT place full dose the fibrinolysis and half dose fibrinolysis, either if we should do or not in patients who are having intermediate high risk patients. And along with that, they have talked about the contraindications of the patients. We have that all the contraindications like hemorrhagic stroke, ischemic stroke, patient is having surgery, head and trauma, head surgery last 3 weeks. All these contraindications they have talked about. Mechanical support about VA ECMO and surgical embolectomy, though there are no trials which favors in the surgical embolectomy. New techniques about the catheter-based or the USG-based catheter from directed fibrinolysis, though there are also no supportive literature. So in conclusion, they have concluded that for high-risk patients, clinicians should aim to optimize the hemodynamics first until the reperfusion strategies take effect. And for intermediate high-risk patient, where full-dose systemic fibrinolysis is not currently recommended, clinicians must monitor a patient closely and decide whether to offer new reperfusion techniques like catheter-based fibrinolysis. Nimish sir.
Sorry, thanks, Hemraj. It was
yes.
So this is a narrative review of risk of pulmonary embolism in the ICU. So I think basics of pulmonary embolism is very important, that as part of our initial assessment for anybody coming into the ICU or into the hospital for that matter, that we should have a checklist where anticoagulation has been thought of. And I think having this checklist on board has really helped most hospitals to reduce the occurrence of thromboembolism in patients in hospital. So again, a couple of points which I thought were very interesting on the narrative review, and I'd like to get Dr. Srinivasan and Dr. Gargi on board of this, because I would like to have their views into their setups about the use of targeted thrombolysis, catheter thrombolysis in an acute event of pulmonary embolism. Would you be able to shed some light on your experience in your ICUs as to whether you all do it, and if you all do it, are there any specific indications of doing it, and when would you consider it as opposed to just using heparin and or systemic thrombolysis for the both?
Hello?
Yeah, Dr. Gargi.
Yeah, am I audible?
Yeah.
Yeah, so we do have a very good vascular surgery backup, and they are doing this targeted pulmonary arterial catheterization and targeted fibrinolytic therapies. Mostly the patients in which hemodynamic instability is there and some kind of reperfusion therapy is required after the initial hemodynamic stabilization, but we cannot give a systemic fibrinolysis. Maybe most of these patients have like recent history of stroke, maybe a CVA or some other contraindication. In those patients, like I have seen 2 patients in which the vascular surgeon did do this. But the problem with this is usually what we faced in a single sitting, it was not done. In one sitting, part of it was done, and again after a few days it was done. And also even after this, there is again chances of rethrombosis occurring. Like we had one patient of protein C deficiency who has now gone into a chronic thromboembolic pulmonary hypertension stage. In that patient, it was attempted once, and we had another patient with CVA in whom it was attempted in 2 steps, but that patient did not make it. So more practice and more experience is needed. This is my limited experience with this procedure.
Okay, great. No, thanks for your input. Dr. Srinivasan, from your end?
Yeah, thank you, Dr. Shah, for having me and asking this very pertinent question. There are 3 situations in my practice where I have found that catheter-guided thrombectomy and thrombolysis are probably going to be part of your treatment plan. And one is the perioperative patient who embolizes. There are relative contraindications for systemic thrombolysis. Now, these patients, if they develop a pulmonary thromboembolism, especially those who have intra-abdominal surgeries or major spine and orthopedic surgeries, and then subsequently they throw an embolus, these are patients who should go to cath lab a priori, as a first step. The second category of patients are those who had a non-resolving embolus after systemic thrombolysis. You have thrombolized the patient 48 hours from the time of thrombolysis, or 72 hours from the time of thrombolysis. The TAPC doesn't get better. The RV dysfunction persists. Now, these patients need to have a relook angiogram, and instead of going back to the CT suite for a CT pulmonary angio, I prefer to take them to a cath lab and do a pulmonary angio on table, and then take a call whether a residual thrombus can be extracted or lysed for these patients. The third category of patients are those who come in shock and are on multi-organ failure already because of the pulmonary thromboembolism. They are very high-risk candidates. The current paradigm is not recommending surgical embolectomy for these patients, so the chances of these patients actually coming off the cath lab are much higher than they come off the operating room table. So this, in my experience, for the last 4 or 5 years, my paradigm in the management of pulmonary embolism as vis-a-vis catheter-guided therapies has focused on these three subsets of patients.
Perfect. No, thank you. I think most of us would agree that these are the absolute contraindications where you would think about catheter-guided thrombolysis. Although the evidence isn't robust, I think that's where clinical expertise comes into play, where everything can't be based on evidence. The one other feature which I thought over here, although I know it's a pulmonary embolism paper, but they haven't spoken about considering lower limb Dopplers, DVTs, and putting IVC filters in. So again, I think a lot of us would do a baseline Doppler, especially in our critical care and critically ill patients, and would consider IVC filter if we know that there is an impending risk of dislodgement of the thrombus into the pulmonary trunk. Again, so is there? Can I ask Dr. Srinivas again? If do you have any specific cutoffs as to when you would put an IVC filter or when not? So you're muted, Dr. Srinivas.
Yeah. So the problem with deciding on the filter is that anticoagulation comes along with the filter. You can't just put a filter and forget about it. You need to anticoagulate the patient. So now, if there is a patient who got relative short-term contraindication for thrombolysis, but no relative short-term contraindication for anticoagulation, we may do a filter on these patients. But currently, again, the whole paradigm of managing extensive deep venous thrombosis, which has not yet embolized, has actually slowly migrating towards catheter-guided thrombectomy and clot retrievals from the veins. So, if such a patient is actually going onto the table, there is a risk that when you break those clots, some of them can embolize upstream. So we can put a filter, extract the clots, systemically anticoagulate those patients for 48 hours, and then retrieve the filters. So the era is now only about retrievable filters. So that decision is not a big challenge.
Right. And I think in view of time constraints, I'm just going to ask one last question to Dr. Pandit, if that's okay. Dr. Pandit, your take of ECMO in acute PE when somebody's decompensated with a massive PE? Dr. Pandit? Okay, Dr. Mehul, do you want to take that one?
Sorry, can you hear me?
Yeah, I will.
Hi, sorry. I got a little sparse connection. Can you repeat your question if you don't mind, please?
Yeah, so just your take on using ECMO in massive PEs when there is cardiac arrest and impending death.
Well, if you have a situation where you're in a massive P and you've come to a point of hemodynamic severe instability and there's no other option, can you hear me?
Yeah.
Okay, yeah. I think then there is limited choices, Namish. I don't know if there are any other choices.
Right.
I don't think so. There is any other choice. If you're left with that,
And
you're left with ECMO.
sure. And what would your experience be on the outcomes?
To be very frank, limited outcomes, guarded outcomes. It seems to be, I don't recall, but I think there is a registry in the ESLO which talks about a few patients with PE on ECMO.
Right.
And the outcomes were not that great.
Okay. No, I think if you're as sick to go on to ECMO, your outcomes are always going to be guarded. So thank you. And I think if you're okay, let's move on to the next paper, Hemraj.
Yeah, sure, sir. So, this is a paper. This is about acute respiratory distress syndrome. It is a review of recent updates and a glance into the future. And it was published in the Diagnostic International Journal in April 2023. The abstract is the ARDS is, we know that it's a rapidly progressive form of respiratory failure that accounts for almost 10% of admission and 40% of mortality in severe cases. Despite significant mortality and healthcare, the mainstay management remains supportive care only. And we have learned from the SARS-CoV that about the pathophysiology, more of the pathophysiology of the ARDS, looking into the innovative ideas to treat, how we can more innovative ideas what we are using also. Recently, many trials have been published utilizing the different pharmacotherapies. Now, and however, the long-term benefits of these agents still are not known. They have talked about the metabolomics, what they have talked about the different transcriptons and epitomes they have talked about, and along with that, they have talked about the mesenchymal stromal cells. We will see that also, and stem cells transplantations, which are already been used in the HIV patients and skin patients and the patients with SLE and all. They have already used this stem cell transplantation. So in there, they have talked about the diagnostic criteria, which we all know about the 2012 Berlin's definition. The pathophysiology, they have talked about the 3 stages, exudative phase for 7 to 10 days, in which mainstay the cells are the macrophages and the neutrophil cells, which play the main role. After that, there is a proliferative phase in which there is apoptosis or the clearance by our body. That's the defense mechanism, and by the phagocytosis and the recalibration of recalibration by our own body cells. After that, there is the third fibrotic stage in which there are the fibroblast cells, which causes in the many COVID patients remain with the fibrosis, post-COVID fibrosis. They have talked about the phenotyping and subphenotyping of the ARDS also. So does it help or not? Means the patients who we have recognized them that these patients are having this phenotype, and these are the patients who are going to have a severe kind of ARDS if they have gone through the first or second stage, or they will have a this condition post fibrotic phase, fibrosis will be there or not. They have talked about this. The current management strategies, they have talked about the lung ventilation, protective ventilations, about the low tidal volume and the higher PEEP. They have talked about the lower PEEP, higher FiO2. That is, PEEP is low, high FiO2 versus the higher PEEP and low FiO2, and they're used as per the ArtsNet study. They have also talked about the role of NIV. Either we should use it early, we should stay we should intubate the patients for giving a prone position. They have talked about the different modes of the ventilation, what we are using: pressure controlled mode, either volume controlled mode with IRV method, or we should go with the high frequency oscillation ventilation or APRV mode. Though there is no supporting data that whether these newer modes or the older our conventional modes are good. Non-pharmacological methods like prone positioning with the Prosever trial ECMO with a Murray score of more than 3 and a pH of 7.2. Pharmacological agents, Accuracy's trial have shown about the neuromuscular blockade, and the Rose trial again. And in the Rose trial, they have shown that the neuromuscular blockade and with the sedation, they have shown that the neuromuscular blockade was not more superior rather than the sedation, deep sedation techniques. Inhaled pulmonary vasodilators like nitric oxides and inhaled prostacyclines. Steroids, we have already known that steroids have been the mainstay during the COVID ARDS. Antibiotics, due to the multiple resistant bug, we know all the bug CRE and Klebsiella, Acinetobacter, Pseudomonas. Pharmacotherapy in ARDS, these are the recent trials what they have talked about, whether the beta agonist, what we are giving, either in an inhaled form or an IV, like a salbutamol infusion, what they have given in a Balti-2 trial. It has also not seen benefits. Rather, they have shown that the patient is having low blood pressure due to beta agonist and adverse effects were there. The newer agents like Civelastat, which is a selective inhibitor of neutrophil elastase. So what they have tried to hold the condition in the proliferative or exudative phase by acting on the elastase enzyme of the neutrophils. Simvastatins, which act by the inhibiting hydroxymethyl butylase coenzyme A reductase, which is an anti-cholesterol drug, which has also was made use in the HARP-2 trial. They have talked about the vitamin D, that is a alveoli trial, and they have shown that the patients who are having a lower vitamin D levels were having a poor outcomes, worse outcome. This is the newer thing, mesenchymal stromal cells. These are the anti-inflammatory properties, and we have talked like these have been already been used in SLE, HIV patients, and skin patients, and because it affects both the innate and adaptive immune systems. And different trials like a START trial, phase 1, realistic, these are all ongoing trial, and they are under the cohort 3 study what this article talked about. They have talked about the gut-lung interaction, the organisms which are getting transferred from the gut to the lungs, and they are having a dysbiosis, and it is leading, it is causing an increased IL-6 levels. They have talked about the metabolomics and the future directions using gas chromatography mass spectrometry and liquid chromatography mass spectrometry, and along with that nuclear magnetic resonance spectroscopy. So they have talked about metabolomes, which are transcriptomes and proteons, and they have talked about the molecular genetic level, that is the chromosomes and the nucleic acids. If we can halt up these ARDS process at some of the stage by changing these by using the metabolomes. So in conclusion, they have said that clinical trials account for the different phenotypes of ARDS, and as biological heterogeneity in ARDS has significant clinical implications. So initial data and mesenchymal stem cell is promising, and by integrating metabolomic profiling in clinical studies, the goal of personalized medicine may, but still may not be unrealistic. Sir.
Yeah, thanks, Imraj. So again, I think a very interesting paper. I mean, ARDS, we all know, is the holy grail of intensive care medicine, and it's impossible to cover this even in 5 days, forget 5 minutes. But I think a couple of things which I would like to discuss, and if I can start with Dr. Mehul, is Mehul, any specific preferences? I know you had a lot of experience with different modes of ventilation. And at one point, I know you were a big fan and promoter of APRV. So can you give us a brief on your views on any specific mode of ventilation? Yes, so pros and cons of your favorite one.
Well, I think ultimately, Nimish, APRV, it's any of these newer modes of ventilation, they are going to be a little user dependent. Ultimately, at the end of the day, what trials are still suggesting is to follow lung protective ventilation in order to make sure that you're minimizing villi. And what you're reading in all these papers and all these biochemical, molecular level, genomic level studies that have coming out with regards to phenotypes and genotypes is all trying to point over to help to reduce these the incidence of villi. So instead of me saying that no, because I'm happy with using APRV, but I've seen a lot of people have their personal biases towards it. I would still keep a simple message across about low tidal volume. Try to still see if you are able to use driving pressures, if you are able to get that and you're able to control the driving pressures, keep your to be very simple, to keep your plats, if you can try and keep it below 30 to 25 to 30, that's the best target. Optimizing your PEEP. There is a lot of to and fro with regards to the recruitment maneuvers, whether they should be used, though to be very honest, we see a lot of us using recruitment maneuvers. I probably leave that for the last thing. Proning seems to be working fantastically. So I think at the end of the day, the take-home message from my side would be that stick to the basic protocols. APRV has its role, can be used, but it's a lot. You need to be very well versed with it, and you need to understand the basics behind it. So if you stick to the basics, and if you're able to follow the principles of probably early proning, I think that's a better take-home message.
Okay, thanks, Bill. So question to Dr. Gargi is, oh, sorry, Dr. Gargi has just sent in a message. She's had an emergency. So if Dr. Srinivas can take this question. So again, I think on the previous lecture, we heard a lot about activated C protein and, you know, the new kids coming on the block and going off with cytosorb as well. I think mesenchymal stem cells are sort of the new kids on the block with personalized or precision medicine, as they call it. Dr. Srinivas, can I get a statement or a comment out of you if what you feel about these?
Yeah, thank you for asking the question. This probably is going to be the future of ARDS management in those phenotypes where there is alveolar membrane denudation, which is the basic mechanism which is predominant in viral pneumonias. Now, viral pneumonias cause the shunt by a different mechanism when compared to bacterial pneumonias, which is more of an exudative process. So where there is a denudation of the alveolo-endothelial interface, the stem cells could be the place where could be the answer to this. Having said that, during the COVID second wave, one of my team members working in another hospital actually did a study on autologous stem cell infusion for these patients with severe ARDS, and he believes that there could be a positive response in selected group of patients. But again, as in most things in intensive care, the word is selected patients. It cannot be a carpet bombing of every patient who comes into the ICU with ARDS with mesenchymal cells. So definitely the technology, this patient selection, the administration needs to be fine-tuned, and we need to understand how to do it effectively. But definitely we are going to hear about this more in future.
Perfect. Thank you, Dr. Srinivas. I think that was very useful, that we know at least somebody's on the move and has tried these, and it does show promise. So in the interest of time, ARDS can never stop, but I think I'll have to make a hold on to that. And let's move on to the last paper. Hemraj.
So this is a paper which is it is a meta-analysis basically. That is about the non-invasive respiratory support after extubation. It is a systemic review and a network meta-analysis. It is done and it is the third in the number in the series of respiratory failure and mechanical ventilation conference reviews, and it was published in the European Respiratory Review series. So the background, what they have said, that the effect of non-invasive respiratory support, that is either it can be HFNC, bilevel airway, CPAP, or NIV for preventing and treating the post-extubation respiratory failure is still not clear. Our objective was to assess the effect of the non-invasive respiratory support on post-extubation respiratory failure, defined as the re-intubation secondary to post-extubation respiratory failure. That is the primary outcome. Secondary outcomes, they have discussed about the ventilatory associated pneumonia, the discomfort, ICU, and the hospital mortality. They have discussed the mortality in ICU and in hospital differently, and which subset of non-invasive respiratory support has helped in the hospital and ICU mortality, that have also been discussed. They have talked about the length of stay in the ICU and the hospital and time to re-intubation. They have done a subgroup analysis in which they have prophylactically given the non-invasive respiratory system and therapeutic. As per the low and the high risk, they have done a low risk and a high risk group they have made. So in this, they have undertook a systemic review and a meta-analysis of almost 32 RCTs they have taken. 32 RCTs entered the quantitative analysis and compared with the conventional oxygen therapy, non-invasive respiratory support overall reduced the re-intubation, ventilatory associated pneumonia, and NIV decreased the hospital mortality and the hospital and ICU length of stay, and increased the discomfort also, because NIV has increased the discomfort, no doubt. So prophylactically, non-invasive respiratory support did not prevent extubation failure in the low risk or the hypoxemic patient, but it helped in the patient who are the high risk group. In conclusion, prophylactic non-invasive respiratory support system may reduce the post-extubation respiratory failure in ICU patients. So they have talked about the form of non-invasive respiratory support as HFNC, CPAP, bilevel positive pressure, BiPAP. So which is to be preferred in which subset of patients they have talked about. They have talked about the 2017 European Respiratory Society and the practice guidelines recommend that the use of NIV for preventing post-extubation respiratory failure in high-risk patient, but not in the low-risk patient. They have, as per the guidelines of European Respiratory Society. They have talked about 2022 European Respiratory Support Society guidelines recommend the use of HFNC over the conventional oxygen therapy in surgical and non-surgical patients at low risk. They have classified the patient in high risk with the age of 65, more than 65, heart disease, respiratory disease, or severe pulmonary disease. Otherwise, they are classified as low risk. Subgroup analysis they have done in patients who have given prophylactically or therapeutic. Therapeutic they have kept in the patients who are having a respiratory respiratory hypoxemia or respiratory support system was needed in respiratory distress patient. They have classified the patient in ICU high risk and low risk post-surgical patient. Secondary outcome they have discussed in overall population. So in the incidence of VAP, they have noted that HFNC and NIV were better than the conventional oxygen therapy. In matter of discomfort, NIV was giving more discomfort to the patient. ICU and hospital mortality, they have said that NIV, HFNC have no benefit in the ICU mortality, but NIV is better in hospital mortality. ICU and hospital length of stay, NIV is better. In patients who are getting re-intubation, neither HFNC nor NIV was helping out. So in conclusion, in overall population, they have said that non-invasive respiratory support system reduced the rate of post-extubation respiratory failure and VAP compared to the conventional oxygen therapy. NIV, but not HFNC, improved hospital mortality and ICU and hospital length of stay despite worsened patient discomfort. So prophylactically, but not therapeutic, non-invasive respiratory support decrease the rate of extubation failure in high-risk patient, and in post-surgical patient, HFNC was good, but not in low risk and the hypoxia subgroup. So point for clinical practice, what they have said last for treating post-extubation respiratory failure in ICU patient, and prophylactic NIV decrease the rate of extubation failure in ICU high-risk patient, and prophylactic HFNE decrease the rate of extubation failure in ICU post-surgical patient. This is the take-home. Sir, Nimish sir.
Yeah, thanks, Emraj. So again, I think a very comprehensive, systematic review and meta-analysis on this one. Very important is one word which they've, it's just a small sentence that they put on the paper, is that they have excluded. So this paper should not be taken into consideration if for using NIV or what they call as NRS as a weaning protocol, because that is a completely separate patient pool and that is to be excluded from this. This is only to be used for post-extubation respiratory failure and risk of reintubation. What I really like about this paper is that they've included NIV and HFNO both, and they've termed it as NRS. So again, I think the summary from Hemraj is quite comprehensive, where it says that I think HFNO and NIV both go hand in hand. The only place where HFNO scores over NIV is patient comfort. But on the whole, all the positive p-value outcomes are more on NIV as opposed to HFNO. Again, so I'll open it to Dr. Srinivas. Your take on NIV versus HFNO?
I have a little different perspective on this. Now, if a patient who's been extubated, I mean, I'm talking about the non-COPD patients who've been extubated, require some kind of positive pressure ventilation even after extubation. I personally believe there has been an error of judgment in extubating such patients. And most of the time, I think we are resorting to NIV to escape that extubation failure tag on that patient. And I am of the firm belief that extubation failure is an independent predictor of morbidity and mortality in the intensive care unit. If your patient was doing well gets intubated within 48 hours of extubation, either the primary process which necessitated intubation of the patient was not addressed completely, or there has been an error of judgment in liberating that patient from mechanical ventilation. So I am not very keen to use the term extubation for patients. I would rather get them liberated from mechanical ventilation. So if either you extubate them or you put them on NIV, if they're still stuck on the machine, they are not liberated from mechanical ventilation. That's my perspective. As far as HFNO is concerned, yes, those patients who don't require any pressure support, but who need a little bit of CPAP, maybe 4 or 5 of CPAP, but also require graded oxygen therapy, the HFNO probably is a good tool to be used in good hands. But again, has to be tailored therapy, like fluids, like antibiotics. There has to be a prescription for oxygen. This is my firm belief that you need to prescribe how much oxygen, when to give, what to monitor, when not to give, and when to stop. If these 5-6 points in checklist are ticked off, I think HFNO is probably a more elegant tool than NIV in non-COPD, non-immunocompromised patients.
Yeah, thanks, Dr. Srinivas. You must have seen a spark in my eye. Being a chest physician, I can't tell you how happy I am when you say that oxygen needs to be prescribed, because day in and day out, my always battle with the wards and the nurses and the other teams is that oxygen is misused. In our COPD patients, in our type 2 respiratory failure patients, invariably, without a prescription, everybody gets normal saturations, which in fact, as we all know, is detrimental. So I can't tell you how happy I am that you brought up the problem of oxygen prescription. I'm telling you, I was a trainee in England, and since the BTS started auditing oxygen prescriptions, which is back in 2008, if I'm not mistaken, I think oxygen is a prescribed drug in the NHS, and without an oxygen prescription about target saturations and how you want to deliver it and the method of delivery, either via venturi or with nasal prongs or with a face mask or with an NRBM, the nurses will not. They will keep harassing the junior doctors to come and tell them how they want it, without which it will not be prescribed. So I think that's a very important take-home message. I think we must incorporate all this into our clinical practice. So thank you for bringing that up. Mehul, one last statement from you, because I think we are already 10 minutes over time, about HIV, HFNO versus NIV.
As far as when I've seen it in post-op surgical patients, I think HFNO has a very good role. However, with these, I mean, I have a little slightly different opinion than what Srinivas has with regards to extubation failures, because there is multiple. It's a multi-play of a lot of things when it comes to a post-op patient, and a lot of things are not under your control. So in certain cases, we tend to use the NIV just to re-optimize the patient, whether it's got to be his respiratory efforts which are poor, and whether we just need to tide off those small collapsed areas where you may not be helpful with an HFNO because he's probably a mouth breather, or we're not able to land up giving that much of a PEEP. But definitely HFNO is a very good tool and is underused, is what I believe. We've used a lot of it overseas, and it has a very good scope.
So great. No, so thank you. And all I can say as my closing remark would be that COVID has been a big teacher for us. We've discussed proning, which has reoccurred and researched post COVID, and HFNO, whose utility and utilization both have exponentially increased post COVID. So with that, I'd like to conclude this session.